Kind Thank you all for joining us today. Today we are going to discuss on management of pain part 2, that is on opioids. We do have an eminent faculty joined here, Dr. Sunil Kumar. It's my personal privilege to welcome you here, sir. Thank you for joining us. And our facilitator, Sister Anu, has also joined us. Thank you for joining, Sister. And for further session facilitation and faculty introduction, I invite Sister Anu. Over to you, ma'am.
Good afternoon, everybody. It's a big pleasure for me and an honor for me to introduce Dr. Sunil Kumar. He is one of the best faculty who can take this session for you today, pain management and again on opioids. He is the additional director of Trivandrum Institute of Palliative Science, which is a WHO collaborating center, Pallium India. You all know this. He has a diploma in palliative medicine and master's in palliative medicine from Cardiff University, UK. He has got more than 15 years of experience in palliative care, clinical experience in palliative care, and he is heading clinical service, academics and research in Pallium India. And all these activities are overseen by Dr. Sunil Kumar. Over to you, sir.
Thank you, Anu, and senior Anu. And good afternoon, everybody. So I shall share my presentation. Is it visible now?
Yes, sir, it's clear.
Previously you might had sessions on the opioids which are used in step 1 and 2, NSAIDs, adjuvants. I hope that has been covered. And we are now moving on to the step 3 in opioids in the WHO analgesic ladder, which are available in India. There are many opioids available in other countries, but we will particularly talk about two opioids today, morphine and fentanyl, and a little bit of the mechanism of action of opioids. And we know that when we use morphine or any other opioids, we have a lot of terms. So we will talk about the practical aspects, then side effects, which is one of the common area of concern for everybody. And it is also important to understand the prices of different opioids, because there are some opioids which are very costly, and if somebody prescribes the costly opioid, then patient may not buy that, and you have to understand that if patient is not using the medication properly, or because of they are poor, then they will come to you and will tell you that I don't have pain relief. And what you will do, you will increase the dose of the medicine without knowing that patient is unable to buy that medicine. So it is important for us to understand the price of different opioids also. So this is the WHO analgesic level, and all of you are very familiar with this. And in the step 3, if the patient has severe pain, we have to use step 3. So step 3 of analgesic WHO analgesic ladder includes opioids for moderate to severe pain, plus or minus non-opioid, and plus or minus adjunct. So all of you know that non-opioid again includes paracetamol and NSAIDs, and adjuvants are those medications whose primary action is not pain relief, but is helpful in some painful condition. For example, tricyclic antidepressants. The primary action of tricyclic antidepressant is it is used to treat depression, but it is helpful to treat neuropathic pain, and that's how it becomes adjunct. Okay, with this introduction, I am moving on to today's session. So you can see a patient here. So if you see a patient like this, what is your biggest concern? You can either unmute and speak, or you can give your response in the chat box. Anybody? A patient is coming to your hospital, and you are the person um, who is in the casualty. What you do first for this patient? We'll ask about the complaints. Okay. Yes, Sivakar. Uh, what else? Uh, what else can you read from this patient? What is his problem? What do you think is his problem? Vitals, then chief complaints. Okay. Sylvester, sister, pain. Okay. From his facial expression, we have to understand that he is in severe pain, isn't it? So rather than, it is important that we should look the vitals, but the primary concern for us as of now is his facial expression, saying us that he is in severe pain. So that should be our concern. So what would you do if a patient comes to you with severe pain like this? This is a patient, yeah. What would you do? Assess pain, yes. We have to assess pain. That's correct. Yes. After assessment, what will you do? After assessment, suppose you are going to see a doctor with severe pain. What is your expectation? What should the doctor do? You are going to see a doctor with severe pain like this. So what is your expectation from that doctor? Pain medication administration. Yeah. When you became the patient, you have the answer. I want pain relief. But when I asked about this patient, you are first going to see pain assessment. It will take long time, and then that's where you stopped. But when you became the patient, you told pain medication administration. So okay, so what pain medication would you give for this patient? According to WHO analgesic ladder, he has severe pain. So which step of WHO analgesic ladder would you select for this patient?
We would like to go for the second step of ladder WHO.
Second step.
Yeah.
Can you explain why second step, Sister Mahbub?
Because if you go for the third step, he might go into deep sleep and all, and again we want to analyze the thing.
Okay. Okay. Thank you. And I can see there are a few response about step 3 opiates. So what you have to understand is the WHO analgesic ladder has to be used properly. So if the patient has mild pain, start with the step 1. If the patient has moderate pain, start with step 2. And if the patient has severe pain, you can directly go on to step 3. And that's why this WHO analgesic ladder has been put into place. Okay, you have to go to step 3. So, uh, so this is a patient, a 56-year-old man with the carcinoma of the larynx, and he came to us with severe pain around neck. It is 10 by 10, and there is no radiation, and the pain is continuous, and he is unable to sleep because of pain for the last 2 weeks. So, what medication for you told WHO step ladder, the third step can be used. So what medication would you administer for this patient? Round the clock morphine. Yeah, that's true. Okay, so in this patient, if you have injectable preparation of morphine, that would be the choice because it will give faster pain relief. Oral morphine will take time to give pain relief. So, you can see this patient after the oral injectable morphine titration. After an hour or even before an hour, the patient is smiling. Okay. So how will you do an injection morphine or intravenous morphine titration, or it is called as IV morphine titration or IV morphine trial, etc. So how do you do intravenous morphine trial? You have to administer injection morphine 1.5 milligram at every 10 minutes interval. Okay. So injection morphine 1.5 milligram at every 10 minutes interval. So what is the immediate side effect that you expect by administering injection morphine to a patient? What is the immediate side effect you expect? So I saw why injection morphine and not oral morphine. So oral morphine, it will take time. We maybe 2-3 hours to give pain relief. We don't know how much dose would this patient require. But if you give morphine injectably, that will give pain relief maybe after 4 or 5 doses for most of the patients. So faster pain relief. So a patient with very severe pain, they would like to get, or even when we become patient with very severe pain, we also want to get pain relief faster, isn't it? We do not want to get pain relief after 3-4 hours. We want to get it immediately if possible. So that's why this if patient is coming with a very severe pain, then you have to give if you have injectable morphine, you have to give intravenous morphine trial. So what is the immediate side effect you are expecting? Yeah, Arathi has told respiratory depression. Divakar also respiratory depression. Anything else? Okay. So the immediate side effect is nausea and vomiting. Okay, it is not respiratory depression. Respiratory depression is not very common. So you have to give a medication which will prevent nausea and vomiting. So what would you give? You have to give injection metoclopramide 10 milligram IV, followed by injection morphine 1.5 milligram at every 10 minutes interval. So what is the strength of injection morphine available in your hospital? Anybody knows?
50 milligram in
Yeah,
2 ml ampules.
2 ml. Okay. So where are you from, Sister Alpine? Which state? You are muted.
Sister, may I help you?
Okay, whatever. So for us, again, it is 15 milligram, but it is 1 ml ampules. Okay, so what we do is we dilute 1 ml of morphine with 9 ml of normal saline. So total 10 ml of the solution that contains 15 milligram of morphine. So each 1 ml of this solution will contain 1.5 milligram. So that's how 1.5 milligram is given at every 10 minutes interval. And how long would you continue to give? There should be an endpoint. I saw a question in the chat. How long would you continue to give injectable morphine? Or when would you stop injection morphine? So this is the answer. If the patient has satisfactory pain relief, or if the patient develops sleepiness, whichever be the first. Okay. So this is the dose that we can give for that patient. There is no maximum dose. Some patient may require 4.5 milligram, some patient may require 9 milligram, some patient may require 15 milligram, and there are some patients who require thousands of milligrams of morphine. So there is no maximum dose. But usually when you need more and more doses of morphine, that means it is not purely opioid responsive pain. Okay. So when you administer injection morphine, you can make a chart like this, which includes time, pulse rate, respiratory rate, blood pressure, pain score. Is the patient drowsy? Or what is the dose of injection morphine? And suppose this patient came to us at 10 a.m. You will first look at the vitals. Then you will ask the pain score. Now the pain score is 10. Patient is not drowsy. Then you will administer 1.5 milligram of morphine. And then you will wait for 10 minutes. So at 10:10, you will again assess the vitals. You will ask the patient pain score. Patient says now pain score is 7/10, and patient is not drowsy. So you will give another 1.5. Then wait for another 10 minutes and again assess all this. And at 10:30, you can see this patient pain score has come down to 1. So that's an indication to stop morphine trial, because patient has got the satisfactory pain relief and patient is not drowsy. Okay. So this patient received total of 4.5 milligram. So is it is this injection morphine titration or IV morphine titration? Is it an inpatient procedure or outpatient procedure?
Inpatient.
Inpatient. Okay. Any of you use injection morphine for your patients? Okay, this is you can do this safely in an outpatient setting. Okay, we do at least 1 or 2 injection morphine titration every day in our outpatient department. So this patient received 4.5 milligram of IV morphine and he has got good pain relief. So now you have to send the patient home. So how will you convert this injectable morphine to oral morphine after intravenous morphine titration? How many milligrams of morphine to be given orally for this patient? Any idea? Just okay. So you can actually give the okay 1/3. Anisha says 1/3. Yeah, in a way, Anisha is correct, but not 1/3. It is 3 times of injectable morphine need to be given orally. But this conversion is applicable only when the patient is on continuous IV infusion for at least 24 hours. Okay, this patient has received injectable morphine 3 or 4 doses. So that will not produce a sustained blood level. Okay, so when you give morphine, injection morphine continuously for at least for 24 hours, that will give a continuous or sustained blood level of morphine. But here only you have given 4 or 5 doses. So you need not multiply it by 3. You can actually convert the same dose of IV morphine to oral morphine. Okay. So you have given 4.5 milligram of IV morphine as in a titrated fashion. So you can convert it into 4.5 milligram of oral morphine. But 4.5 milligram is not practical. So the uh, practically you can give 5 milligram of morphine. So we have 10 milligram of or tablets. So 10 milligram half every 4 hours. So you can see, just think instead of wake up, it is 6 a.m. So start at 6 a.m. Then at 10 a.m., 2 p.m., 6 p.m. And at bedtime, usually the patient is given double dose. So instead of 5 milligram, the patient will be given 10 milligram. In addition, you can also give SOS dose, which is the same as the regular dose. So the 5 milligram. Okay. So morphine need to be given every 4 hours. And 4 hours is the duration of action of morphine. So as nurses, you will be the people who knows that most of the patients who are in pain, they will be sleeping at 6 a.m. Sorry. So you need not actually wake them up at 6 a.m. but give the first dose of morphine when the patient wakes up. And likewise, you also need not keep the patient waiting up to 10 a.m. If the patient wants to go to bed early by 9 p.m., give double dose at 9 p.m. Okay. And if you do not have injectable morphine, then you need to give oral morphine. So how oral morphine trial is done? You can start with 5 milligram every 4 hourly and SOS in patients who are opioid naive. Opioid naive means the patient who has not taken any opioid. Okay. So if the patient comes to you with severe pain and the patient has not taken any opioid, including the weak opioids, then you start the patient on 5 milligram 4 hourly and SOS. And if the patient is on other opioids, weak opioids, then you can start with 10 milligram of morphine 4 hourly and SOS. So our patient, the patient whom we saw, we started him on 5 milligram of morphine 4 hourly and SOS dose. And with that, he had a very good pain relief. But it lasted only for 2 weeks. But then he required 4 SOS doses of morphine per day. So what shall we do now? And how frequently would you give SOS dose of oral morphine? So shall we try to answer the first question? The patient is taking more SOS doses. In addition to the regular dose, the patient is taking more SOS dose. So do we need to do anything with the morphine dosage?
We can add up.
I can see Divagar says increase the dose. Okay. Somebody else was speaking.
Jewels.
Okay. Adjuvants. Okay. Okay. Sylvester says maybe add up the total dose and divide by 5. Yeah, Sylvester. So what does this means? Patient is taking the regular dose, and he is also taking 4 SOS dose. That means when he takes like this, he has pain relief. That means the regular dose of opioid is not enough. 5 milligram is not enough. So you have to increase the dose of opioid. Okay. So this is where you have to understand that when you will increase the dose of morphine, if the patient is taking 2 or more than 2 SOS dose, PRN means it is SOS. Okay, if the patient is taking 2 or more SOS doses, then you can increase the dose by 30 to 50%. And actually, this can be done every 24 hours. Okay, so every day you can increase the dose of morphine by 30 to 50%. So if this patient, our patient was taking 5 milligram of morphine, okay. If you calculate 30%, that will come to 1.5 milligram. So 5 plus 1.5, it will be 6.5, which is not possible. We cannot give 6.5 milligram of oral morphine because tablet cannot be broken like that. So the next possible increase is 50%. So the 50% of 5 milligram is 2.5. So you can increase it to 7.5 milligram every 4 hourly, or even to 10 milligram of morphine. Okay, because breaking the tablet into 4 pieces, that may not be feasible for everybody. So even 10 milligram of oral morphine is okay for this patient. So how frequently would you give SOS dose of morphine, oral morphine? Suppose the patient has taken morphine at 6 a.m. Patient says, I have severe pain by 6:30 a.m. So what would you do then? Anybody? So I know some of you are using morphine. You can tell me uh, what would you do if the patient has taken already a dose of morphine at 6 a.m. and if 6:30 p.m. patient complains of pain, what would you do? Okay, so you have to understand a little bit of pharmacology. Wait for the action of medicine, Divakar. Yes, so how long it will take, Divakar? So this is the um, plant from which we will get morphine. This is, the scientific name of this plant is Papaver somniferum, but um, lemon call it as poppy plant. Okay, and you can see these are the poppy fields. In India, there are only 3 states where opium or poppy plant is grown legally. So these are UP, MP, and Rajasthan. And nowhere else in India we can grow poppy plant. And you can see the seed-like thing, which is known as pod, POD pod. And the farmers will make small cuts on the pod, and you can see the sap is oozing out. They will collect this sap and dry it um, and um, make it a powder, dry it, and it will be transported to government opium and alkaloid factories from, and they will make morphine powder from this. Okay, so and morphine is absorbed from the upper small intestine. And another thing you should know is that morphine is bitter. So when you powder the tablet for a patient who is unable to swallow, you should sweeten it with something, fruit juice or sugar cane or something. Okay. Um, and these are there are these are the routes through which you should not administer morphine. Sublingual route. It is not advisable to give morphine because absorption is very, very low. Again, buccal and gingival route is also not advisable. And some people say that or will advise you to give morphine sublingually, and maybe the patient can have pain relief. But then what you have to understand is if the patient has good pain relief, the patient has probably swallowed it. That's why the patient has pain relief. So after uh, intake of oral morphine, that will go to the upper small intestine, and from there it will be absorbed into the blood vessels, and from blood vessels it will go into portal vein, and from portal vein to liver, where metabolism takes place, where metabolism of morphine takes place, and then these metabolites are liberated into the systemic circulation. So it is mainly converted into two metabolites. One is known as morphine 3 glucuronide and the other is known as morphine 6 glucuronide. In short, it is known as M3G and M6G. And the component which is formed in less quantity, that is M6G, is the component which will give you the pain relief. M3G doesn't have much action in our body. Okay. So M6G is the component which will give you pain relief. So you saw that the morphine has to go into GI tract and it has to go into blood vessels, then portal vein, and to the liver where metabolism takes place, and then it has to be liberated into the blood for getting pain relief. So this will take some time. So the morphine pain relief might start by about half an hour, but the peak of pain relief will be by 1 hour. So it is advisable to wait for at least 1 hour before you administer the next dose of morphine. So you have to wait for 1 hour. Okay. So this is the same patient. So our patient, his pain is stabilized with 10 milligram of morphine 4 hourly, but he says it is very difficult to take it every 4 hourly. I often forgot to take it every 4 hourly, and then I will be in pain. In addition, I have a lot of other tablets. This is a common situation, isn't it? If somebody asks us to take amoxicillin 3 times daily, how many of us would take it 3 times daily? And how many of us would complete 5 days? So this patient is reasonable. He is asking for something else. He says, if you are, if you give me morphine less frequently, I can take it. Do you have any option? Anybody?
We can shuffle the dose.
So can you explain? Shuffle the dose means what do you want to do exactly? This patient was taking 10 milligram every 4 hourly. We can make it 6 hourly with SOS order in between. Yeah. So we know that morphine has a duration of action of only 4 hours. So if you make it 6 hourly, that means the patient will have pain in between. Patient says, I should not have pain in between, but you should give me less frequently. Is that possible? It is possible. How? you can actually give patients sustained release morphine. And the duration of action of sustained release morphine is 12 hours. So the morphine which we were talking previously was immediate release morphine, which has a duration of action of 4 hours. But we have uh, sustained release morphine, which has a duration of action of 12 hours. So this patient was taking how many milligrams per day total?
40 milligram,
Is it 40?
40, 10 milligram, 4 hourly,
That means how many times patient will take morphine in a day?
4 times.
No,
Sorry. Uh,
it's 6 times, isn't it?
yeah.
So total this patient is taking 60 milligram. So if you convert this into sustained release morphine, what would be the dose of morphine you are going to use in this patient? The duration of action of sustained release morphine is 12 hours. So what should be the dose of sustained release morphine? It is 30 milligram BD, isn't it? 30 milligram BD. But you also need to understand that sometimes this patient can also have breakthrough pain in between. Okay. So in that case, you have to give morphine. It is not sustained release. You will give immediate release morphine. Okay. For pain in between, that is breakthrough pain, you will give immediate release morphine. So what are the preparations of morphine available? We have syrup, tablets and capsules, both immediate release as well as controlled release. Immediate release is also known as fast acting morphine. Controlled release is also known as sustained release morphine. Then we have injections. So our patient is on 10 milligram of morphine every 4 hourly for the past 6 months. And he had a very good pain relief. But one day this patient was brought to the casualty with excessive drowsiness. And on investigation, the total count is elevated. Blood urea is 20 milligrams. Serum creatinine is 5 milligrams per deciliter. Will you do anything with morphine dosage for this patient? Why this patient is drowsy? What is the reason?
Maybe he's over sedated.
Addicted to morphine.
Addicted to morphine. Okay, I can see Anusha says accumulating side effect of morphine, then stop morphine. Okay, what is the reason this patient is becoming more drowsy? So you have to understand that morphine is excreted from the body through kidney. Okay, so it is excreted from the body through kidney. So what happens if patient has renal failure? This patient has a serum creatinine of 5 milligrams per deciliter. That means this patient has renal failure. So what would happen? The morphine and its metabolites will get accumulated in the blood. And that's why the patient is becoming more and more drowsy. Okay. So what you have to do, you have to actually reduce the dose of morphine. So you have to, instead of a 4 hourly morphine, you have to give morphine maybe 8 hourly or 12 hourly. And also instead of 10 milligrams, make it 5 milligrams. Or you have another choice. You can use safe renal opioids. So what are the opioids which are renally safe? fentanyl and methadone are supposed to be renally safe opioids. Fentanyl and methadone. Okay, so this patient, Mr. X, now after coming to the casualty, you have reduced the dose of morphine to 5 milligram 8 hourly. And after 2 months, this patient was unable to swallow anything, including morphine, and even he is unable to swallow the water. And the patient is at home, and the patient is probably terminal, maybe a few days to die. What will you do for this patient for pain relief now? Anybody? Patient is unable to. We can give through rails tube. Yes. Fentanyl patch. This patient is going to die in a few days. So would you put a rails tube for this patient? It is not necessary. IV morphine, how the patient is or patient family member is going to administer IV morphine, and for that matter, would your hospital allow to give injectable morphine to be given to patient who is at home? So you have to understand what are the routes through which you can administer morphine. Okay, you can administer morphine orally, and what are the other routes? Intravenous or subcutaneous. Then you can administer morphine parectally. Okay, morphine can be administered parectally. Then epidural and intrathecal. So for this patient who is terminal, you can administer morphine parectally. So the same dose, the parectal route is comparable to oral route. So whatever be the morphine patient was taking orally, you can administer it parectally. So this patient was taking morphine 5 milligram 8 hourly. So you can give 5 milligram parectally. So you can take the morphine tablet 5 milligram and add 2 drops of water, make it a paste and rub it over the rectal mucosa. That will give the same pain relief. And the only thing which you need to be careful is you should not put this morphine into the fecal matter. It should be in the rectal mucosa. So we'll move on to another patient. Okay. This is a lady who is a 55-year-old lady with carcinoma of the colon, has abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine every 4 hourly, and she has very good pain relief, and she is not taking any SOS doses of morphine. And here again, the patient says, I do not want to take it every 4 hourly. So the doctor advised this patient to replace the morphine with fentanyl patch. Okay, but the next day patient is coming to you and tells you that I do not have pain relief, so I removed the fentanyl patch after 5 hours. So what would you do now? Patient who was on morphine converted to fentanyl, but now the patient says, I don't have pain relief. What are you going to do? Anybody? Those who are using fentanyl? So there are a few points which you need to understand about fentanyl. Okay. So you can see this is the fentanyl patch, and there will be a protective film which you have to remove before you stick it to the body. And once applied, you can see fentanyl will be liberated into the subcutaneous tissue. So it will first form a subcutaneous tissue storage. And from this subcutaneous tissue storage, the fentanyl will be liberated into the blood vessels. So to form a subcutaneous tissue storage, it will take about 12 hours. Okay, it will take about 8 to 12 hours. So the patient um, will have some pain relief by 8 to 12 hours. But our patient removed the fentanyl patch after 5 hours. So that's not, that should not be done because you have to actually educate the patient that this will give pain relief only after 8 to 12 hours. So it should not be removed. So you are the people who are going to actually educate the patient regarding this. Otherwise, patient will come like this. Okay. So after, so till this 8 to 12 hours, you have to continue the previous opioid. So you have to continue the morphine for 12 hours after application of fentanyl patch. And the duration of action of fentanyl patch is 3 days. Usually it will last for 3 days, but some patients by 48 hours, it may be enough. And another thing is that it can be, the fentanyl patch can be applied anywhere in the body, but you should not shave the area because shaving will produce abrasions in the skin, which will increase the absorption. And heat or temperature is also going to increase the absorption. So if patient has fever, that is going to increase the absorption. Um, uh, the patient should avoid hot water bath or blankets, etc. should be avoided. And one of the important thing is this transdermal fentanyl patch is not suitable for patients with unstable pain. So what is unstable pain? Pain um, which has many peaks and troughs. Okay, sometimes the pain will go up, then suddenly will come down, and then suddenly shoot up, come down. So this will continue. This is known as unstable pain. So in those patients, you should not use fentanyl patch. For those patients whose pain is controlled with short-acting opioids like morphine, then you can convert it into fentanyl patch if the patient is affordable. And in addition to transdermal fentanyl patch, injection is available, and there is another preparation known as oral transmucosal fentanyl citrate, which is like a lollipop, and that will give instantaneous pain relief. So if the patient has pain during movement, then you can actually rub this lollipop over the buccal mucosa, which will give instantaneous pain relief. Okay, and actually fentanyl is more potent than morphine. 100 milligram of morphine is equal to 1 milligram of fentanyl. Okay, so 100 times more potent than morphine, and 60 milligram of oral morphine equivalent per day. That is, if a patient is taking 60 milligram of oral morphine per day, you can replace this with 25 microgram per hour fentanyl patch. And if the patient is taking 90 milligram, it would be 37.5. At 120 milligram means it is 50 milligram of fentanyl patch. So this is another patient, Mr. P, who is on tab morphine 50 milligram per hourly. She attends your clinic with severe pain, and you have injection pentazocine and oral morphine tablet. Injection pentazocine is 4-twin. Okay. So how will you manage the pain of this patient? What would you give? I would like to see some response. Anybody? Patient is already on injection tab morphine 50 milligram 4 hourly, but Now she is coming to your clinic with very severe pain, and you have injection pentazocine and oral morphine tablet. How are you going to manage pain of this patient?
We will give injection for pentazocine.
Injection 14. Okay, thank you. So can you explain why do you want to give injection pentazocine? Yeah, Sister Annie says 14. Divakar also says 14. Yeah. Why do you want to give injection 14? Okay, let's see. So for that you have to know a little bit of pharmacology about opioids. Okay. So how the opioids act in our body? It acts on opioid receptors to give pain relief. Okay. So opioids act on opioid receptors, and mu, kappa, and delta are the opioid receptors. So when the opioids attaches on these receptors, it will give pain relief as well as side effects. Okay. And according to the action on receptor, opioids can be classified into three: agonist, antagonist, and agonist antagonist. So an agonist means when um, the opioids which will combine with opioid receptors to produce physiological action. That means it will give pain relief and other side effects. That is known as an agonist. And antagonist means what is an antagonist? Can anybody tell me what is an antagonist? Opposite to agonist, isn't it? But suppose what are the examples of antagonist? Naloxone and naltrexone. And actually opioid antidote is naloxone. So that is an antagonist. But if I give you naloxone, will it have any action in your body? There will not be any action. If you are taking opioid, then that will reverse the action of opioid and you will have pain. Okay. But agonist antagonist means on some receptors, these opioids will act as agonist, but on some other receptors, it will act as antagonist. And most of the opioids which we know, that is morphine, fentanyl, tramadol, codeine, all are agonist. Examples of antagonists are naloxone and naltrexone, and agonist antagonists are buprenorphine, pentazocine. These are the two common or usual medications which others use. And you can see a graph here. So on the left hand side, it is the agonist. You can see on the x-axis, it is the dose of opioid you are administering, and on the y-axis, it is the pain. Suppose you are giving an agonist. This patient has pain till here, that is up to 10. You are giving morphine, which is an agonist, and you give morphine this much, you will get this much pain relief. But when you increase the dose, it will give corresponding pain relief. Okay, when you increase till here, it will give full pain relief. That means when the dose of opioid is increased, it will give corresponding pain relief. This is known as no ceiling effect for analgesia. There is no ceiling for analgesia. Okay, when you increase the dose, it will reduce the pain. That is known as no ceiling effect for analgesia. But look at on the right hand side graph, where you can see up to a point, you can increase the dose and it will give corresponding pain relief. But after this point, even if you increase the dose, it will not give any pain relief. Okay, so buprenorphine and pentazocine, that is what will come in this group of agonist and agonist. So if a patient is on high dose of agonist opioid, you should not give an agonist antagonist to patient, and because that will actually going to increase the dose of increase the pain. Now we'll move on to adverse effects of opioids. So adverse effects can be divided into two: side effects and toxic effects. So what is side effect? Side effect means these are adverse effects with the therapeutic doses. So what are the side effects? These are constipation, nausea, vomiting, sleepiness and tiredness, itching, dry mouth, urinary hesitancy. The first three are the common side effects, and the next three are rare side effects. And about constipation, almost all patients will have constipation if you prescribe or put patient on opioid. So you have to continue the laxative as long as the patient is on opioid. So suppose you should not stop laxative in between for a patient who is on opioid. So what is the drug of choice for opioid-induced constipation? You have to give stimulant laxative. That is disacodine. Is an example of stimulant laxative, or sodium pycosulfate, or senna. These are the three examples of stimulant laxative. And you should not give the powder-like laxative, like methyl cellulose. It is actually contraindicated in patients with opioid-induced constipation. So you have to continue the stimulant laxative as long as the patient is on opioid. So that's what you have to remember. And the next side effect is nausea and vomiting. It occurs in almost 1/3 of the patients, but it will be there only for the first few days, maybe up to 3 to 5 days. And this is due to the action of opioids in our brain in an area called chemoreceptor trigger zone. And how do you treat the opioid-induced nausea and vomiting? You can give haloperidol, metoclopramide, or domperidone. So we use metoclopramide 10 milligram TID for 3 to 5 days. And after that, you can stop the antiemetic, because this side effect, nausea and vomiting, is self-limiting. So in case of opioid-induced constipation, you have to use disacodil, not lactulose. Sleepiness, and next side effect is sleepiness and tiredness. This occurs in about again 1/3 of the patient, but this will be there only for the first few days. So after a week, it will be over. The sleepiness and tiredness, our body will get accustomed to it. So the patient will be active. You need not give any medication. So that was the side effect. Now we will move on to toxic effects. So what are toxic effects? It is the adverse effect when the administered dose is higher than required for pain relief. So you are giving more than required dose. So then that will produce some adverse effects which are known as toxic effects. So how do you know these are toxic effects? Usually the patient will present with delirium, myoclonus, and drowsiness. Okay. Delirium, myoclonus, and drowsiness. And some of you were talking about respiratory depression. How common it is? It is not at all common. It is very, very rare. Okay. So this is a systematic review which says the patients usually take opioids orally. Okay. And we usually increase the dose in a titrated fashion. So which ensures that respiratory depression is unusual. And when respiratory compromise does occur, we should seek an alternative explanation, such as does the patient has pneumonia, does he has pulmonary embolism or cardiomyopathy, or are you administering another sedating medication such as benzodiazepine? Okay. So and that's about respiratory depression. And now I will move on to the comparative prices of opioids. So you can see a patient who is on morphine 5 milligram every 4 hours. And for this patient, he need to spend only 3 rupees 50 paisa. But to get the same pain relief, you have to give 300 milligram of tramadol. and the patient needs to spend 24 rupees to 50 rupees. But to get the same pain relief with fentanyl patch, the patient has to spend 250 rupees to 400 rupees for 3 days. And if you use methadone, which is another opioid in the third step of analgesic ladder, which is also cheap. You can see only 4 rupees 50 paise per day. So with this, I will end my session. If you have any doubts, you can ask. Okay, one more clarification regarding bisacodyl and lactulose. Actually, even though many people use stimulant laxative as a drug of choice, that is bisacodyl, sodium bicarbosulfite, senna. Some people also use osmotic laxatives like lactulose. But you can combine the osmotic laxative like lactulose with bisacodyl. We use bisacodyl as the first choice because lactulose has many problems. One is that it is its peculiar taste, and it is maybe some 50 times costlier than bisacodyl. So we usually give bisacodyl. Bisacodyl is the drug of choice. Okay. Okay. Please repeat 3 medicines for constipation. So one is bisacodyl, then sodium picosulfate, and senna. SENNA. During morphine administration, can we use sedation? You should be careful because I told you that the opioids alone usually will not produce respiratory depression. But when you administer large doses of benzodiazepine, then it can be a problem. So you can use benzodiazepine, but use it judiciously. Maybe smaller doses of benzodiazepine if needed. Any other doubts?
We have a case presentation for today. If there are no more questions, shall we move on to the case presentation?
Thank you so much, sir. From the chat box, I can see that it was, you have they had so many questions and you have answered all the questions simultaneously. And hope everything is clear because this is one of the most important session and sir has taken it in the best, as simple as possible so that we all can understand it and applicable in our daily life, especially the economic part of it. Like, when we talk about the drugs, we should also know whether the patient can afford it or not. So that is also very much important. Same way, we have to ensure that patient is comfortable or the symptom is relieved. So shall we move to the, thank you so much, sir. Thank you so much, sir. Shall we move to the case presentation? Today's case presentation is by Sister Neeta Jose from Holy Cross Hospital, Shankumukam. I ask Sister to present the case study.
Sister, you are muted. Yes.
Good evening, everyone. A 41-year-old female was admitted with complaints of abdominal pain and backache, and patient is restless and not able to sleep. and her diagnosis was adrenocortical with liver metastasis. Presenting complaints were complaints of abdominal pain and backache, and patient was restless and not able to sleep. And the history of illness, patient had complaints of severe backache since 2 months and high blood pressure and headache. She also had nausea and vomiting. Did not get any relief with medication. And she was taken for further investigations, and then she was diagnosed as adrenocortical carcinoma with liver metastasis. And by the time she became very fatigued and restless. And on examination, patient was conscious, drowsy, and she had backache, she was very fatigued and sleeplessness. Her BP was 220 by 130 mm of Hg. Her pulse was 86 per minute. Temperature was 98.6 degree Fahrenheit. Saturation 94%. And physical examination, abdomen was soft and bowel sounds were present. The treatment and significant investigation. She was given analgesics, opioid analgesics, sedatives, antihypertensives. Then to provide her comfort, she was given air. Care of the body was taken care of. Then provided nutrition and psychological support. In the psychosocial aspects, 41 years old lady suddenly developed backache and abdominal pain. Her husband is an auto driver. She has only one girl who is studying in the 10th standard. Along with the pain and other discomforts, these also made her very sad. The medications given her was where the tab nicardia retarded 20 mg BD, tab morphine 5 mg 6th hourly, tab UD-Liv 300 mg BD, syrup Dufelac 15 ml/h, tab Telma-H BD, tab Raso 20 mg OD. Then she was also given injection tramadol 100 mg IV infusion SOS and tab Alprax 0.5 mg SOS. The main concerns were to relieve the pain, to provide her comfort and sleep, to provide adequate nutrition, and to give her psychological support. In summary, the 41 years old lady suffering from adrenocortical carcinoma with liver metastasis. She had severe backache and abdominal pain, high blood pressure, headache, nausea, vomiting, sleeplessness. Administration of opioid analgesics, sedatives, and other analgesics gave her temporary relief. What are the problems faced by this patient? What can be done for this patient?
It's open for discussion. The floor is open for discussion now. Can you keep that last slide? What is it? Question. It's okay, open for discussion. Because today we have learned about pain medications in the last three classes were on pain medications, and today we have stressed on opioids. Can you show the medicine chart? and have a look on it. Can you come in? Can everybody have your feedback on it? Mehboob, please, Srivastava, raised hand.
Yes, ma'am.
Yeah.
Good afternoon to everybody. I think we'll have to increase the morphine dose, which is only 5 milligram.
This morphine dose can be given 5 mg 4th hour. That is the correct dose.
Okay. Anyone else? Was the patient getting frequent breakthrough pain?
Yes.
So that time you were giving injection tramadol.
Yes.
Sir, I think you can lead the session now. Sunil sir.
Senior, can you come on to the psychosocial status of this patient?
One second, sir.
Yeah. Is this patient married? What about
Yes,
her
married.
family? Family, only one.
One girl, her husband is an auto driver and she has only one girl studying in the 10th standard.
Okay. How is the relationship?
Family relationship is good.
Does she know about her disease?
Yes.
Okay. Please come on to the first slide. Yeah. Okay. So what was her insight actually? Was it going to cure, or what was her insight about the disease?
She was very depressive, not able to, not talking.
Why she has depressed mood? Is it because she knew about all the present condition, or is it due to something else?
When her husband told that because of her pain and big thinking of her child.
Okay. So Sister Nida has asked two questions. What are the problems faced by this patient? So whenever we see patients in palliative care, we actually look at the total suffering of the patient or total pain of the patient. And you have to segregate this into 4 circles. So in one circle, you can put the physical problems. So what are the physical problems experienced by this patient? One is pain, sleeplessness. Was she able to do independent activities of daily living, household work, etc.?
She was doing, but recently she is not able to do. All the
Okay.
time lying down only. Need some assistance.
So in addition to pain and sleeplessness, her functional status is decreased. Then from a psychological point of view, sister said that she is very much depressed. And that may not be clinical depression, or might be, we don't know. Then the patient might be thinking about her child, who is a girl, and what will happen to her in future, about her husband. So those are the psychological problems that she might be experiencing. And from a social point of view, if she is unable to go out and her mobility is restricted, uh, she's going to be alone because her husband is an auto driver who need to go out for earning the livelihood, and then her child need to go to school. So probably she might be alone when she's at home, and there might be many thoughts coming into her mind. So socially she's isolated, and financially they might be poor, and so these are the social and financial aspects. So physical, psychological, social and financial, and maybe spiritual or existential distress. Why I have done all the good to everybody, but still this has happened to me, or is this a punishment from the God? So these are some questions the patients with existential distress ask. So these are the, and this is known as total pain or total suffering of the patient. So whenever we see a patient in palliative care, we should put the suffering in this four circles. So what can be done for them? Can you come on to the prescription, senior? So as the morphine was given only 4 hours, 6 hourly. So that can be made 4 hourly. And actually, tramadol is a weak opioid. So it is not good to combine a weak opioid with a strong opioid. Morphine is morphine is a strong opioid. So instead of tramadol, if you need, you have to increase the dose of morphine and give SOS dose of morphine whenever the patient has pain. So that's what one thing has to be done. And Difalac is lactulose. So I would prefer Disacodil, which is again very cheap compared to Difalac. So I would give Disacodil 5 milligram 2 HS rather than Difalac. And Alprax, if she has clinical depression, then we have to give antidepressants. But Alprax, it might be okay to give SOS. Yeah. So you can manage pain and sleeplessness. Probably when her pain becomes better, she might sleep better. That's what I believe. And maybe you have to talk to the patient and listen to her to find out more of her concerns. What are the things that is disturbing her? Then from the psychological point of view also, there are many problems, but probably you have to listen to her. That's what you can do. You will not be able to do some assurance that we will look after your child or something like that. We will not be able to do that, but at least listen to her concern. Just by hearing somebody, it will give some relief for the patient.
Sir, instead of tramadol, what can we give?
Give morphine itself. Whenever the patient has pain, you give morphine itself. Okay. So we told that morphine can be given every 4 hourly, and in addition, you can also give SOS dose. So once you give morphine, after 1 hour, if the pain is not relieved, give another dose of morphine. But you have to see whether the patient has delirium, myoclonus, or drowsiness. Myoclonus means it is the jerky movements of the body like this. It may be in a part of body or whole of the body. So delirium is irrelevant talking, and excessive drowsiness. You may not be able to wake up the patient. So these are the signs which you have to look for when you administer opioids. If it is there, that means the administered dose is higher than the required. So you have to temporarily stop opioids. Maybe 1 or 2 doses of morphine has to be stopped. And when you restart, that is when the patient becomes alert. You restart it with a lower dose.
Okay, sir.
Hope everybody is clear about the drugs part.
If you have any doubts, you can ask. I would like you to know a few things from this session. One is morphine has to be administered every 4 hourly. But if the patient with SOS dose, but if the patient has renal failure or severe liver failure, instead of 4 hourly, it might be administered 6 hourly or 8 hourly, 12 hourly, depending on the parameters. Then whenever you prescribe opioids, you have to give a stimulant laxative along with opioids. So continue with bisacodyl. Then a weak opioid need not be combined with strong opioid. If you are giving morphine, you use SOS dose of opioid. Don't give weak opioids like tramadol or codeine. And there is no maximum dose for morphine. And look at the toxic effects like delirium, myoclonus, and extreme drowsiness when you need to titrate the dose of morphine. Bisacodyl, it can produce, or one of the side effects of bisacodyl is colicky pain, but usually the patients will not have colicky pain with bisacodyl because you are giving just 10 milligram HS. And if the patient has colicky pain, then you might add a liquid paraffin along with bisacodyl. That will reduce the colicky pain.
Any further questions?
Lactulose, the most important thing is its taste. Then it is, I told you, it might be some 50 times more costly than bisacodyl. If 2 tablets of bisacodyl may cost 2 rupees 50 paise, but I think 180 ml of lactulose, that will cost about 300 rupees. And at least you have to give 15 milligram and 15 ml of lactulose 2 times daily. That is 30 ml HS, 30 ml per day. So that will last only for 6 days. So if you give this bisacodyl, that will be about maybe 15 rupees for 6 days compared to lactulose 300 rupees. And lactulose can also give a bloating sensation.
If there is no further question, shall we wind up?
Okay, thank you.
Thank you so much, sir. Thank you so much.
There is one more
Clarifying.
question. Morphine, how long can be given, sir?
Suppose a patient with cancer and he is not on any treatment. The patient has pain because the malignancy has infiltrated tissues or nerves. So if you are unable to treat those, then you have to continue. You have to continue with morphine because the lesion is there. As long as the lesion is there, the patient will have pain. You have to continue indefinitely. But if you are going to have some curative treatment, suppose a surgery is going to be done, or radiotherapy is done, or chemotherapy is done, the lesion is going to reduce, or even it might disappear. So according to that, the pain will be less, and the patient will then develop toxic effects. So that means you have to reduce the dose of morphine.
I think there is no more comments. We can wind up the session. Thank you, Dr. Sunil, for joining us today. Thank you for your valuable time. And thank you, Sister Anu, for facilitating with us. Thank you all for joining us today. And I will be sharing the feedback link in your WhatsApp group so that you can fill it up. Thank you all. We'll see you on the next session.
Right. Thank you.
Bye.